Hi, everybody, and welcome to our module on secondary hypertension. In the video on hypertension, I explained how most cases of high blood pressure, about 90%, are what's known as primary or essential hypertension, and the cause of this condition is not clear. In a smaller subset of cases, about 10%, the hypertension is secondary to some other disorder, and what we're going to talk about in this module are causes of secondary hypertension. Your blood pressure is determined by a combination of the cardiac output and the total peripheral resistance. So all of the causes of secondary hypertension are disorders that either raise the cardiac output or raise the peripheral resistance. So for example, the cardiac output will rise in the setting of renal salt and water retention, and this is a common mechanism of development of secondary hypertension in the setting of kidney disease. There are also a number of causes of secondary hypertension that we'll discuss in this module that involve increased total peripheral resistance. The key vessels that determine your total peripheral resistance are the arterioles. Any disease process that constricts the arterioles will raise the peripheral resistance, and that can cause secondary hypertension. So for example, in the setting of vasoconstrictors like catecholamines or increased tone from the sympathetic nervous system, the total peripheral resistance can rise, and that can lead to secondary hypertension. The first cause of secondary hypertension that we'll discuss is chronic kidney disease. Most of the patients you will see clinically who have secondary hypertension will have renal disease. It's the most common cause of secondary hypertension. This is a picture of a man receiving dialysis to help you remember that. Over 80% of patients who have some form of chronic kidney disease also have hypertension. There are multiple mechanisms responsible for this. First of all, the sick kidneys cannot excrete sodium normally, so there is sodium retention. There's also increased activation of the renin-angiotensin-aldosterone system and also increased sympathetic nervous system activity. All of this occurs among patients with chronic kidney disease. In the pulmonary section, I discuss obstructive sleep apnea in detail. This is a sleep-related breathing disorder where patients have repeated episodes of apnea where they stop breathing during sleep because of airway closure. This is a drawing of a man wearing a CPAP machine to keep the airway open at night as treatment for sleep apnea. Sleep apnea is often associated with hypertension. The sympathetic nervous system is ramped up from the repeated episodes of apnea, and that leads to hypertension, and treatment of the sleep apnea may reduce blood pressure. And in clinical practice, when you see patients with hypertension, you often will screen them for sleep apnea with a sleep study, because if you identify the disorder and treat it, the hypertension will get better. There are a number of drugs that can potentially cause secondary hypertension, and I'll go through some of the important ones in the next few slides. The first class of drugs are the NSAIDs. These are non-steroidal anti-inflammatory drugs. I've listed the names of some of them on the screen here. These drugs are taken regularly by many patients for chronic inflammatory conditions like osteoarthritis, and they can potentially lead to hypertension. The reason for this is because these drugs inhibit cyclooxygenase, which is important in the kidneys for synthesis of prostaglandins. Patients taking these drugs have decreased synthesis of prostaglandins in the kidneys, and one prostaglandin that's especially important in the kidneys is prostaglandin E2. This is a renal vasodilator, so in patients taking these drugs, they can have low levels of PGE2, and that can lead to vasoconstriction in the kidneys. Prostaglandin E2 preferentially dilates the afferent arteriole, so in patients taking NSAIDs, there can be vasoconstriction of the afferent arteriole. This will decrease the renal blood flow and also decrease the glomerular filtration rate. This leads to less sodium and water excretion, and therefore the effective circulating volume of plasma increases, and this can cause hypertension. This can also potentially exacerbate heart failure. Heart failure patients who take high dosages of NSAIDs can potentially develop pulmonary edema and end up in the hospital from retention of fluid. Oral contraceptive pills can potentially cause hypertension. Women taking these medicines can see a mild increase in blood pressure. The reason for this is because these pills are estrogen and progesterone analogs, and both of these hormones can cause a slight rise in the blood pressure. Pseudoephedrine is a nasal decongestant. People take it when they have upper respiratory infections and runny noses. This is the structure of pseudoephedrine on the bottom right side of the screen. You can see that it is similar to the structure of epinephrine. Therefore, it will function as an alpha-1 agonist. This will lead to vasoconstriction of blood vessels in the nasal passages, and this will decrease nasal blood flow. However, a secondary effect of this drug is that it can raise the blood pressure and cause secondary hypertension. In the immunology section, I talk about cyclosporin and tacrolimus. These are immunosuppressants. They function by inhibiting calcineurin, and both of them commonly cause hypertension in patients taking the drugs. That's because they lead to renal vasoconstriction, which leads to salt and water retention. And a high-yield thing to remember about both of these medicines is that diltiazem, a calcium channel blocker, is the drug of choice for treating hypertension caused by cyclosporin and tacrolimus. The reason for this is that diltiazem impairs the metabolism of cyclosporin and tacrolimus, so it boosts the drug levels. This allows you to use a lower dose of cyclosporin and tacrolimus. In other words, you are treating the hypertension with diltiazem, and also you are able to use a lower dose of cyclosporin so that you get less hypertension caused by the drug. Primary aldosteronism is a classic cause of secondary hypertension, so let's talk about that now. In primary aldosteronism, there is an excessive level of aldosterone secretion from the adrenal glands, and importantly, this excess aldosterone secretion is not due to increased activity of the renin-angiotensin-aldosterone system. That's why it's called primary, because it is not secondary to the RAAS system. This can occur when there is an adrenal adenoma. When this happens, it's called Conn syndrome. This can also occur due to bilateral idiopathic adrenal hyperplasia. So to understand the clinical features of primary aldosteronism, we have to review the normal effects of the hormone aldosterone. So aldosterone promotes sodium reabsorption in the distal nephron. So when there's excess aldosterone around in primary aldosteronism, there'll be excess reabsorption of sodium. And anytime the kidneys reabsorb sodium, they also reabsorb water. So this will increase the effective circulating volume in the vascular system. That's going to raise the cardiac output. And together, these effects lead to hypertension in primary aldosteronism. There's simply more fluid volume circulating in the vascular system, causing a higher blood pressure. It's super high yield to know, however, that the serum sodium should be normal. And that's because ADH release from the pituitary gland is intact in primary aldosteronism, and that will maintain a normal serum sodium level. Aldosterone also promotes potassium excretion, so in primary aldosteronism there's more potassium excretion in the urine, and this can lead to hypokalemia. This is not present in all cases of primary aldosteronism, but it can be. And then aldosterone also promotes acid excretion in the urine, so when there's primary aldosteronism, patients can develop a high serum bicarbonate and a metabolic alkalosis from increased acid excretion. You might think that because aldosterone stimulates sodium resorption and expands the effective circulating volume, that it would lead to signs of volume overload on physical exam, but it does not. And the reason for this is because of a phenomenon known as aldosterone escape. Usually patients with primary aldosteronism have no pitting edema or rales or increased jugular venous pressure or any other sign of volume overload. The reason for this is because aldosterone promotes sodium and fluid retention, which leads to hypertension. However, the hypertension activates compensatory mechanisms. There are a number of these that have been described. One of the important ones is increased A&P release from the heart. The increased A&P increases sodium and free water excretion by the kidneys. The result is diuresis and a normal volume status. However, the compensatory mechanisms are not able to bring the blood pressure back down to normal. What this means is that patients with primary aldosteronism will have hypertension in absence of signs of volume overload on physical exam. So the clinical features are resistant hypertension, which means hypertension that is difficult to control with medications, also hypokalemia, and usually a normal volume status on physical exam. The diagnosis requires proof that there is renin-independent aldosterone secretion. This means there will be a low plasma renin activity, yet high aldosterone levels. And these are the most important things for you to know for step 1 of your boards. They're going to want you to understand the basic physiology of the renin-angiotensin system, and they're going to want you to know that the renin level is low, yet aldosterone is high in this condition. The drugs of choice for the treatment of primary aldosteronism are spironolactone and eplerenone. These drugs are aldosterone antagonists that will block the effects of the high levels of circulating aldosterone. It's high yield to know for your boards that ACE inhibitors and ARBs are going to have no effect in patients who have hypertension from primary aldosteronism. That's because, as we just discussed on the last slide, angiotensin II levels are very low in patients with primary aldosteronism. The RAS activity has been dialed down in response to the high levels of sodium and water that are being retained because of high aldosterone release from the adrenal glands. Remember that the way ACE inhibitors and ARBs work is by disrupting the RAS, but RAS activity is already very low, so there's nothing to disrupt. Or another way to think of this is aldosterone release in primary aldosteronism is not dependent on angiotensin II stimulation. It's autonomous, and therefore if you inhibit the RAS and decrease the effects of angiotensin II, it won't have any effect on aldosterone release, which will continue to be high and will continue to cause hypertension. Little syndrome is a very rare disorder that may cause secondary hypertension, and clinically it looks just like hyperaldosteronism. However, it's got a different cause. This is a classic trick board question, so don't get fooled. Little syndrome is a genetic disorder where affected individuals are born with increased activity of a sodium channel in the kidneys called ENaC. ENaC stands for epithelial sodium channel, and I talk about it in more detail in the videos on nephron physiology in the renal section. Normally, aldosterone promotes the activity of this channel, so if it's overactive due to a genetic disorder, this will lead to a similar clinical syndrome to hyperaldosteronism. Children with this condition have hypertension and hypokalemia, and in a board question, when you see this, you'll be inclined to say that the problem is hyperaldosteronism. However, in little syndrome, aldosterone levels are low. That's because the problem is not the hormone aldosterone. The problem is the channel, ENaC, that aldosterone promotes the activity of. Here's a slide from our renal video on nephron physiology, and in that video, I talk about how aldosterone promotes the activity of this sodium channel, and that's how aldosterone leads to more sodium reabsorption by the kidneys. This sodium channel is called ENaC. It's found in the principal cells of the collecting duct. So if you have hyperaldosteronism, you naturally have more activity of that channel. If you have little syndrome, you also have more activity of that channel, but not because of high aldosterone levels. Instead, you have more activity of that sodium channel because of a genetic disorder. This is a classic trick board question, and don't get fooled. Also be aware that the way you treat hyperaldosteronism is with the drug spironolactone because it blocks aldosterone effects. That drug won't work in little syndrome because the problem is not aldosterone. Instead, you have to use a drug that blocks the activity of this channel. That is the drug amiloride, which is another potassium-sparing diuretic, but unlike spironolactone, it does not block aldosterone effects. Instead, it directly inhibits the sodium channel, ENaC. Pheochromocytoma is a very rare cause of secondary hypertension. These are tumors that secrete catecholamines like epinephrine, norepinephrine, or dopamine. I talk about these in more detail in the endocrine section modules on the adrenal gland, and that's because these tumors usually arise from the adrenal gland. The classic triad of symptoms, which is only present in a minority of patients, is palpitations, headache, and episodic sweating. The tumors tend to release catecholamines in a fluctuating manner, and this results in episodes where patients feel palpitations, develop a headache, and break out in a sweat from the catecholamines. Some people remember PHE in pheochromocytoma for palpitations, headache, and episodic sweating. Most patients with these tumors have hypertension, and one of the most important things to know about these tumors for step 1 of your boards is how it's diagnosed, because that involves biochemistry. These tumors are diagnosed based on catecholamine breakdown products like metanephrines and VMA, and I talk about these in more detail in the biochemistry section. Cushing syndrome is another endocrine disorder I discuss in the endocrine section. It results from excess cortisol. In clinical practice, this usually occurs because patients are taking exogenous steroids for an inflammatory condition like rheumatoid arthritis. However, it can also be caused by other disorders like Cushing's disease. This is when the pituitary oversecretes ACTH. There can also be tumors that secrete ACTH. Small cell lung cancer classically does this. In addition, there can be adrenal tumors that secrete cortisol. In all of these situations, there will be an excess of cortisol in the body, which leads to many of the signs and symptoms of Cushing syndrome. One of them is the presence of hypertension. That occurs because cortisol leads to increased vascular sensitivity to adrenergic agonists like epinephrine and norepinephrine. Renal artery stenosis is another classic cause of secondary hypertension. This occurs when there is vascular disease involving the renal arteries that leads to decreased blood flow to the kidneys. When the kidneys sense decreased blood flow, they activate the renin-angiotensin-aldosterone system, and this leads to secondary hypertension. And a key physical exam finding that's not always present in actual practice, but is often present in board exam questions, is the presence of a renal bruit. If you have narrowing of the renal artery, as I've shown in this picture here, that will create a bruit that you can hear when you place your stethoscope over the abdomen of the patient on the side where the kidney is affected. As I said before, when there's decreased blood flow to a kidney because of stenosis, that kidney will increase the amount of renin release. That will activate the renin-angiotensin system and lead to salt and water retention, and that causes secondary hypertension. Now, one thing to know about renal artery stenosis is that the stenosis is often unilateral, meaning one kidney has normal blood flow, but the other kidney has decreased blood flow. In this situation, the normal kidney attempts to compensate for the volume retention by the sick kidney, and as a result, there are no signs of volume overload on physical exam. Much like we talked about in primary aldosteronism, this condition can be difficult to diagnose because patients will only have hypertension and will not have other signs of the kidney absorbing too much sodium. Here's a picture to help you better understand unilateral renal artery stenosis. Let's imagine this kidney on the left has a narrowing of the renal artery. Therefore, it will be receiving decreased blood flow compared to normal. For this reason, it will secrete more renin. In addition, autoregulatory mechanisms will be activated so that the kidney will retain more sodium and attempt to raise the plasma sodium level. This will lead to an increased activity level of the renin-angiotensin-aldosterone system. It will also lead to secondary hypertension. The normal kidney, however, will sense the high blood pressure and decrease its renin production. In addition, the normal kidney will begin excreting more sodium. In other words, it will try to lower the plasma sodium level. This is called pressure natriuresis. It's an autoregulatory mechanism of the kidney. So we therefore have a situation where one kidney is releasing more renin and holding on to salt and water. The other kidney is releasing decreased renin and excreting more salt and water. The result is that the patient will be euvolemic. However, the renin-angiotensin-aldosterone system remains elevated. The normal kidney cannot completely compensate for the increased renin secretion by the sick kidney, and therefore hypertension remains. And it's very important you understand this slide. This is a favored topic of board question writers because they can ask you about the one kidney which is sensing low blood pressure and the other kidney which is sensing high blood pressure, and test your knowledge of the underlying renin-angiotensin-aldosterone system. Another special feature of renal artery stenosis that is very high yield for you to know for exams is the fact that patients who have renal artery stenosis are heavily dependent on angiotensin II for normal kidney function. In the setting of renal artery stenosis, normal glomerular filtration rate depends on angiotensin II. This is because angiotensin II constricts the efferent arteriole and maintains the GFR. To understand this, let's imagine that we have a glomerulus and we have the afferent arteriole on the left side of the screen and the efferent on the right. In the setting of renal artery stenosis, there is decreased blood flow entering the glomerulus via the afferent arteriole. As a result, the renin-angiotensin-aldosterone system is activated, as we just discussed, and angiotensin II will constrict the efferent arteriole. This will cause fluid to back up behind the constriction and be pushed into the nephron through the glomerulus. In other words, the flow across the glomerular membrane and into the nephron is dependent upon this vasoconstriction in the efferent arteriole, and that is driven by angiotensin II. What that means is if you place a patient with renal artery stenosis on an ACE inhibitor, which lowers the level of angiotensin II, you can potentially decrease the GFR significantly and precipitate renal failure. And this is a special feature of renal artery stenosis, and it often comes up on board exams. Most patients with renal artery stenosis have atherosclerosis of the renal arteries, but there is, however, another cause of renal artery stenosis that does not involve atherosclerosis, and that's a rare disorder called fibromuscular dysplasia, or FMD. This is a blood vessel disease. It's a vascular disease that leads to obstruction to blood flow. It's common among women, especially women in their 40s and 50s. And in contrast to other forms of vascular disease, this does not involve atherosclerosis, and it's also not inflammatory like a vasculitis. What happens in this disorder is that for reasons that are poorly understood, usually the medial layer undergoes a process called fibroplasia, which basically means the medial layer develops an abnormal growth of fibrous tissue. This leads to narrowing of arteries and causes stenosis. And then between areas of stenosis, aneurysms form. So what you get in blood vessels is called a string of beads, where you have an aneurysm followed by a narrowing, followed by another aneurysm. And it looks like this on angiography if you image the blood vessels of women who have this disorder. Most commonly, this disorder involves the renal arteries and leads to renal artery stenosis and hypertension. It can also involve the carotid arteries and lead to stroke. And when it leads to renal artery stenosis, it can cause secondary hypertension. So this is a disorder you should think of in a younger woman who has evidence of a string of beads on her angiogram and has no risk factors for atherosclerosis, the usual cause of renal artery stenosis. Another very rare cause of secondary hypertension is coarctation of the aorta. I discuss this condition in detail in the videos on congenital heart disease. In this condition, the patient is born with a congenital narrowing of the aorta. As a result, the blood pressure is elevated in the upper extremities behind the narrowing. The final cause of secondary hypertension that we'll discuss is autosomal dominant polycystic kidney disease. I talk about this in detail in the renal video on cystic kidney disorders. This is a genetic disorder that results from mutations of the PKD1 or PKD2 genes. It presents in adulthood with hypertension, usually at a relatively young age, and imaging of the kidneys will show evidence of extensive renal cysts. This is a picture of what the kidneys can look like in a patient with polycystic kidney disease. And the mechanism of hypertension is believed to be increased activity of the renin-angiotensin-aldosterone system caused by the presence of the cysts. And that concludes our module on secondary hypertension.